So I'm really, really excited to welcome you to today's webinar on leading the way in bariatric care and community wealth with Dr. Kath Williamson, and the host today will be Norma Finlay, who is our A1 Head of Clinical Operations. So really, really welcome to everyone who has attended today, but also just a note to say that if you can't, if someone's been unable to and that you know that they've registered, please let them know that we'll be sending out a post-webinar email just with a link to the full live webinar, and any kind of information that's been covered that will be relevant will be in that as well. So don't panic if you have to leave early or you're not able to attend. It will all be recorded, and you will get access to that as well. There will be a Q&A throughout. I know Norma's going to be kind of asking Cass some questions as well, but also if there's any questions that come up, please put them in the Q&A box or in the chat, and I will do my best to go through them at the end. Apologies of my voice, I have a bit of a cold, so thankfully you won't have to listen to me too much. But again, thank you so much for joining. I will hand it over to Norma, who I think will just give a better introduction of everything going on today. So thank you.
Thank you, Adele, especially when you're feeling so unwell, so I appreciate that. Yeah, I'm delighted to be able to welcome you today, and especially to Kath Williamson. Kath is an absolute wealth of knowledge in all things plus size and bariatric care. And yeah, we can talk quite a lot. I know that Kath and I could talk for some time. We could probably talk for the rest of the day together. So we will be mindful of the time to allow you to have your time for questions. So we definitely encourage that. So, without further ado, let me just see if I can move this on. Here we have Kath on the red carpet, no less. Kath, if we could just start, please, by asking you what brought you into the field of bariatric care within the community from, I believe, moving and handling. If you could tell us a little bit about yourself and how you were drawn to bariatric care, please.
Yeah, absolutely. And hello, everyone. And thank you for making time in your busy days to come along and listen to me. I really appreciate that. I guess it starts even before I got into manual handling, where my background is as a district nurse since the late 1990s, which makes me feel very old. But I guess what I saw from about the early 2000s was more and more people on my caseload in Edinburgh, or various caseloads that I worked in, who were living in larger bodies, and our struggles in caring for them. And so that kind of piqued my interest, because often we don't care for this patient population very well. So I started doing I did a secondment to bariatric surgery in 2010, and I very quickly learned the trauma that people experience, and it wasn't talking about carbs and calories, it was talking about traumatic events they'd had. So that taught me something. But then I did a master's in weight management and waited for this population to come up, the housebound population, and it never did. So I was a bit disappointed in that. And then, yeah, it was just, as is so often the case, it's looking after key individuals that really stretch us as professionals, where we feel our care isn't brilliant. And there was one gentleman in particular that I looked after who slept on a bench in his house, on a kind of a cushion that is the same foam that the buses used. So it wasn't pressure relieving at all, wasn't able to go to the toilet. And my care for him in the 2 years, he was just in his early 40s, so caring for him really kind of pushed me. And I guess it was through doing care that wasn't great, the evidence base wasn't there to support it, that got me into thinking about the evidence base that we use, because I basically felt very vulnerable in what I was doing. And yeah, then a bit of manual handling while I was doing my PhD as well, because obviously it's such a key area for individuals, manual handling. That's often how we become aware of them. So yeah, community nursing and district nursing is the background that I got here by.
And I'm aware when I listen to you speak, Kath, and when we've spoken in the past, you can sometimes not pick me up on, but I'm consciously aware of the terminology I use. So is it important that we are, as health professionals, is it important that we are mindful about, we hear terms such as plus size or bariatric or obesity? What would you say to how we refer to plus size or bariatric?
Yes, thank you for bringing this up as one of the first issues, because it's one of the most questions I get asked most often is, well, I don't know how to talk about it with people, therefore I don't. And I think language in so many areas is an issue for us increasingly in society, and size is no different. And just to put people's minds at rest, there isn't one term that we can use. There's been lots of research done in this area, and it really depends on the individual that you're working with. So if you're working with an individual, I usually say to them, what term are you most happy with? How would you like me to talk about size in relation to you? And usually, quite often what I hear is that people struggle with the word obese. They find it quite medicalized. I have had one person say to me, just call it fat hen because that's what it is. And I'm like, okay, but I probably wouldn't do that, unless you'd said, and just do that with that individual. Plus size tends to be the term that's used in manual handling, and that comes from retail back in the kind of 1960s and 70s. It's not wrong. People know what you're referring to, but you wouldn't hear that used in a weight management or obesity conference. So what we would use there is person first language, where you would talk about someone living with obesity, someone living in a larger body, just in the same way that we would talk about someone living with dementia or living with diabetes or living with cancer. So you wouldn't say someone was cancerous or a demented person. And I guess it's a little bit the same when you're talking about an obese person. It's that person first, the person comes first, and then they're living with either excess weight or obesity. The term I try to avoid is morbid obesity, which basically means deathly obesity. And that was the World Health Organization term back in the 1990s, but it's increasingly not true. And in terms of people don't die as much, we're often helping people live with obesity. But it also just, if you say that to someone, that can be quite depressing for them. So that's one of the terms I'd move away from. And it presents me with a real issue when I'm writing about it as an academic. What term do I use? So I will tend to use severe obesity if I'm working with kind of medical or health professional audiences, but it's a difficult one to get right. I would just ask the individual, if you're working with them, what terms are suitable for them.
One of the terms I think I've heard you refer to is person living in a larger body. And I suppose what I thought that makes complete sense. You're describing size, but I suppose one of the things, or perhaps the old style way of terminology, was it referring to BMI of any kind, or did that help clinicians understand what size we're referring to, or weight we're referring to at all?
Yeah, so the BMI categories are used widely. So you get your BMI 25. So excess weight would be kind of, or overweight would be 25 plus, and obesity would be BMI 30 plus. But BMIs have come in for a real bashing in recent years. It's not an individual applicable term, and we know that there are individuals for whom it will not work well. So kind of bodybuilders. But at a population level, it's really useful because we have to have cut-offs and rough guides. And I think as well, when we're working in something like manual handling, we're aware that BMI is perhaps a starting point, but actually it's never the end point, because where people will wear their weight and how they present in terms of body size are very different for the individual, and we need to be assessing around that. So yes, I will use BMI sometimes, but never as like that's the final assessment, and we should never stop there. And I think you just said, why do we use these different terms? And it's really important for trust. So building trust with people, and these are often people who have found that stigma is very widespread in health and social care. And so actually what that means is they back off from using services, and their service utilization is actually reduced because of the stigma that they experience. They don't want to engage with services. So we need to work really hard to engage people, and actually using language that is kind and is inclusive is the first signal that we can give to someone that stigma is an issue, and our awareness of that. So that's why it's important right up front, I think.
I suppose that leads on to one of the questions that was asked with regards to community, is understanding the patient's experiences and what you would foresee as some of the common challenges you see within not being that critical acute stage, but actually within the community and trust. I would, you've just referred to. Are there any other challenges you would say are quite common that you see that people avoid accessing community services?
Yeah, so I think often as OTs and district nurses, we get very privileged access into people's houses, into their very kind of intimate living conditions, and we get to go in and see. And so the gentleman that I referred to kind of earlier, when I first went into him, he wasn't able to go to the toilet. So he was using kind of puppy pads that he ordered off the internet, which actually was a really good coping mechanism. So he was standing up and doing his business into them, and then he would fold the puppy pad up and put it into a bag, a black plastic bag, and then he would wipe the floor with a kind of wipe, and then put that into the bag. And so when I went in, there were about 40 or 50 bags of body waste in this tiny hall in a tenement flat in Edinburgh, and that's why the GP had asked me to go in. And he was so ashamed about that, and the fact that he wasn't managing this. He wasn't able to get to the bin outside to put the body waste in. So he'd stopped his family visiting. He'd stopped anyone going in. He had nobody providing care for him. And I went in and I was like, do you know I could get you a commode so we don't have these bags of body waste? And I was like, that's the answer. And he said to me, and who's going to empty the commode? And actually, I sit here on my bench and eat, and I do everything here. And he was like, I don't want to be looking at, my business when I'm sitting here eating my food. And it was just brought me up really short, that whole person-centered approach that we need to use. It's about how people are living, and it needs to be acceptable to them. And I worked with him for 2 years, and he taught me so much about coming from that person-centered viewpoint. So things that we think are good, so bariatric size beds, for example, and we think, oh yeah, we'll get one of those in. Actually, they can disable people more, and actually often these issues haven't happened overnight in someone's home. So he slept on the bench with pillows kind of propping him up, but he has an armchair that his larger legs, kind of one of the legs went onto the armchair, and he had it tied to the seat with a bit of material, so it never went too far away, and he would pull it to him with a stick. All these coping mechanisms that he developed, and I was walking into that, and I needed to work with him. And I'm sure many people on the call are like nodding, going, yeah, get with the program, you're being a bit slow. But it's all of that. We have solutions that perhaps we go to things like MBE and we see equipment and we think fantastic, but actually it needs to work for the client in their individual situation. And very often the emotional side of that is up amount for people, and how they're going to incorporate that into their day-to-day living, and we have to go at their pace.
And what about the wider community, so within the person's home? But then I guess I've heard you speak before, Kath, around, well, actually, has the healthcare professional, the clinician, considered if appointments haven't been attended, well, has the journey been mapped through? So what about access? What is access to those community services? What does it look like for that person? And is that something that you come across?
Yeah, absolutely. And I think for people who are housebound, generally that's an issue. And then for people of size, and you'll notice I'm using different terms throughout the presentation, because there's no right one, just to give people an option to pick one that works for them. That can be very difficult, because if we say, or even if someone isn't housebound, it may be attending their GP, and it's about how they're going to get there, how they're going to be able to park. Is there a disabled parking space? When they get into the GP, does that involve walking up steps if that might make them very out of breath? Are there chairs that they can sit in their GP practice that can take their weight? Are there chairs in the waiting room, in the consulting room? Are the toilets floor mounted, or are they wall mounted, which means that actually they take different weights? Do we have a blood pressure cuff? And it can be very easy, I think, as professionals, for us to kind of say, this blood pressure cuff doesn't fit you, making it the person's problem, where actually it's our issue to have the equipment to hand and to say, I need to go and find an appropriate blood pressure cuff for you, because we're giving the message of, you're not welcome here, you're different, we're not catering for you, you are kind of outside the norms, and all of those things. Even though we're not verbalizing explicit stigma, that's kind of structural implicit stigma, and that gives people the message really that they're not welcome, and they'll think I'm not going to go back. So it's those type of things that are really important, thinking about it from their perspective.
And just that, do you feel that ties in then with, I mean, obviously your area of expertise now and your research is around, which we'll come on to, is around that housebound person, but does that then affect, withdrawing, the lack of trust? Would you say that in your experience, have you observed that has an impact on mobilisation and deterioration at all, or can it impact? Would that be true to say?
Yes, I think that relationship that you form with someone and the trust you have, and them thinking that you're coming at it, trying to look at it through their eyes, really helps them to think about how you work together. So that language that you used at the beginning helps them to think that you're aware of the issues of size, you're aware that this is difficult for them. And I think it's, the assessments that we're going to use in manual handling and mobilisation are the ones that we would apply to everyone. They're just for plus size, we're maybe thinking about the equipment being slightly different, but the assessment of, can this person do it independently? How can they move? What are their coping strategies? Are all still there. And sometimes we can, how can I say this? We can look at the person and think, oh my goodness, how are we going to move them? And we've not asked them about what they can actually do. And Tracy Carr, who was at MBE, and she's a kind of plus size model, she will often say about how she got admitted to hospital and she was sitting in a chair and they were thinking about how they were going to get up some stairs. And no one asked her if she could get out of the chair and walk them. And they spent, you can spend a lot of staff time thinking, how are we going to do things? But it's always in collaboration with the person, as we would do for any kind of manual handling, and that, so that you're working together on it. Yeah, definitely.
Yeah, it makes it. But I guess that therein lies the difficulty, is the assumption that this, you mentioned earlier on when you spoke to us, that you said that this hasn't happened, the person has coping mechanisms, so sometimes actually you might be really surprised as to how able and what the strategies that they've taken to, for example, continue to mobilise, to transfer, etc. I suppose there's that risk aversion then potentially, because we realise that if mobility is impaired, which there are obviously the result of carrying a heavier weight can deteriorate mobility, then if there's a risk of falls, we have the falls prevention side of things as well to consider.
Yeah, that's really key in community. And I think one of the areas I would like to push into is rehabilitation of people living with obesity. And that's hard because in community, we're often having that real risk and that kind of assessment of, well, if they fall, what's going to happen? And I think we don't have a lot of evidence base at all. And that's one of the reasons I'm in research. But one of the things that I think increasingly we know is that if we don't keep people moving, then and they lose that ability to mobilize, then it's really, really hard for the person of size to get that back. So I think one of my key messages to staff would be, as much as you can, try and keep people moving. So sometimes I've been involved with people who maybe have a viral illness and they're like, oh, I don't think I'll get up today and get out of bed. And my message would be, yes, we need to keep you moving, even if it's going to the toilet twice a day, to do that. Because actually, if you lose your mobility, what we see is that people don't get it back, and then that becomes a real manual handling issue. So maintaining that mobility is absolutely imperative, and maintaining all the function that they've got, absolutely key. Yeah.
And that might be for a short time. I mean, you mentioned, it's not that weight is not always the issue. There are other medical issues and health issues that the person may have, but enabling that person to continue to mobilise. So even if that's a seated mobilisation or mobilisation within the bed, that there's an attempt made, because you'd refer to Tracy speaking, which I had the pleasure of listening to Tracy speaking, that there's not even an acknowledgement of what the person is capable of achieving.
Yeah,
it's really
and I think
the assistance.
Absolutely. And in my practice, as a bariatric care specialist in the community, one of the things that I come up against is when we've got people at home and we're thinking about beds that they're in and we're thinking about mattresses, and we can look at things like Waterloo's score and it can be quite high, and we'll think, right, well, we'll get them an air mattress. And actually, that's one of the areas where I think we need to really think about our professional judgment, because if we put an air mattress in, that can actually make it quite difficult for someone to move around. And so I would often say, well, let's try and stick with a foam mattress for as long as possible, because it'll enable that independent function. But from a tissue viability perspective, and please listen to this, we need to have that skin care as having that risk assessment and be constantly risk assessing, is the skin being kept okay and intact. But I guess what it is being brave enough sometimes to think that the things we would naturally go to and that our checklists or tools might tell us we need, we perhaps just need to question a little bit with that person who's living with obesity, because it maybe doesn't make the most sense. You've got tissue viability versus functionality. So it's just thinking outside that box a little bit.
Yeah, no, that makes complete sense. And just making sure that the everything is compatible. So the therapeutic seating systems with pressure care is compatible as well. I think we've had some issues where perhaps the person has had a dynamic air mattress, but no therapeutic seating system with inbuilt pressure care, etc. So I guess where's the encouragement to mobilise then to and be transfer and assist a transfer onto another surface? Do you come across where there's missing pieces of the jigsaw, perhaps?
Absolutely, hugely. And I think this is where it's about working with industry. So one of the big missing pieces of the jigsaw for me is that often these people are chair sleepers because they may have quite heavy legs. So we have real difficulties getting people's legs into bed. And actually, there's not great equipment for that. So that can mean either an informal or formal carer needing to do that. And we all know the difficulty getting care packages. But if someone is a chair sleeper, thinking about the pressure area care, particularly if they've just got a rise recline without pressure area care built in. And so for something like a repose contour, which we know has a weight limit of, I think it's 139 kilograms, and it's just thinking about, actually often staff will say to me, that's not enough, what will I do? And so working with manufacturers, and I know the manufacturers of the repose contour are just looking a little bit at that at the moment and thinking about, okay, so does that mean we can't use it, or does that mean we use it with a risk assessment? And yeah, I think there's a lot of need for very practical kind of support, particularly around pressure area for kind of chair sleepers. Yeah, lots of things that we could develop. I think we're at the beginning of journeys with this evolving client group, and my hope would be in 10 to 20 years we see a lot more available.
Yeah, I share that. I know, from a seating matters perspective, when we look at the evolution and some of the development of the what we classify as bariatric chairs, but we need to then consider the carer and moving that chair from room to room, for example. So we will often hear carers say it's wonderful, such a benefit, and the person saying they love the chair. But for both the carer and the person's perspective, how can we easily mobilise it between the chair between rooms? And that's where consideration of product development, etc., is. Just now, I think really we're having these conversations, and we'll come on to look at your research to think, where does that fit? But before we look at your research, which is incredibly helpful, I guess we've spoken about equipment and environment, but I think when we think about weight management, or that's not always the priority for the person. The person is living a quality of life, and often it's other health conditions. But we have seen a significant change in weight management, and I suppose with obesity medications or bariatric medications, I don't know if we'd refer to that, but things like Ozempic and Mounjaro. Do you think that's, it's not Mounjaro, it's Mounjaro, isn't it? That's likely to change the landscape then, and how we see changes in weight, I guess, across the population?
Yeah, it definitely is. So one of the privileges I have as a researcher is going to the obesity and weight management conferences. And it's just amazing the treatments that are coming out. And I guess when I started my PhD in 2016, which was really trying to map this population that we see in the community, we didn't have great treatments. So if people did a behavioural treatment, which very few people did, so only 10% of people with severe obesity get referred to weight management, and even less kind of undertake an intervention and complete it. And if they did, then 3% weight loss was seen as a good outcome by NICE. That's not motivating for people with a BMI of 60, and it's not going to change, the manual handling. Whereas with these new medications, we're getting weight loss of, say, 15%, and that's what that's important for me is not the weight loss per se. So it's not the numbers on the scales and saying, great, you've lost 5 or 6 kilos. It's about function and well-being and how that enables people to live a better life. And so the dietitians are getting excited about the weight loss, the medics are getting excited about the kind of cardiac outcomes of that, and I'm getting excited about, does that mean someone's going to be able to go to the toilet by themselves and actually not need social care? Because that's a real win for the person in terms of quality of life, because nobody really wants someone else taking them to the toilet. But it's also a real win for us as organisations in terms of thinking about someone's function and perhaps the equipment they're going to need. So the whole weight management world is really changing quite fast, and it's a lot more holistic, a lot more focus on well-being and functionality and people living lives that are meaningful for them. So the support is a lot more holistic, and it's a lot less on, right, we just want you to diet and lose weight. Yeah, so I think they're game changers, the medications. Unfortunately, the NHS is struggling to get them out there. I think that'll come. As you can imagine, a lot of people are eligible, so they're trying to work out who gets it first. But actually, a lot of people are taking it privately, so the private market is huge. And I think for people who are housebound and equipment in particular, what we will see is people's weight journeys be a journey. So it might be that when they take the medications, then we'll see their kind of shape and their weight change. Now, what we don't know about the medications yet is how long people can take them for and what will happen. And people do need to make behavioural changes. It's not that the medications are a shortcut. And you almost see this real stigma with taking the medications that people are, not doing it the proper way. And I think we have to be careful about that. I think the medications can help, and they can particularly help lessen some of the psychological shame and fear or failure that people feel about not having managed this just through willpower. But we actually know that the contributors to excess weight are a lot more complex than we thought, and that's been one of the huge learnings for me in doing my PhD, is actually just, it doesn't happen overnight, and nobody would want to live with a lot of the excess weight. People aren't, it's a long journey for people, and so actually having treatments that we can give them now, it's really exciting.
And I suppose that will lead on to your work. You mentioned your research there, and the psychological impact and trauma as well, that it's not just a type of medication. So can you tell us a little bit about the HOPE study, please? That would be very helpful.
I'd love to. Thank you. So HOPE stands for Housebound Obesity Pathways and Engagement. And I guess coming from a community perspective, particularly as a district nurse, we are often as community professionals caring for the lot of the symptoms of the excess weight. So that's lymphedema, breathlessness, sleep apnea, diabetes. And we're caring for those individual symptoms, but not the weight that is causing it. And with these new weight management medications, is the opportunity to shift the dial with the weight and improve all those comorbidities, and improve function. But actually, what I said earlier about very few people who are housebound get referred to weight management. And we're not really sure why that is. I've got ideas, like, actually, can they get to clinic? Are health professionals, wider health professionals, aware of weight management services? Even if the person was referred, would they want to go? And so that's what the HOPE study is really scoping out. It's scoping out about actually what services can we offer to housebound people who do want weight management. And there's so little evidence around that we're asking the specialist weight management services and the wider healthcare professionals and the people with lived experience what their experience is. So, yeah, that's what it's about. And for people on the call who are wider healthcare professionals, I guess there's the opportunity to contribute by saying where you currently fit with that. And what I hear from people is that they don't know about weight management, they don't know how to raise it, they wouldn't know who to refer to. Even if they did, there were long waiting lists, put them off. And I guess I need that evidence and I need that service perspective from people in the field to be able to say to funders, this is why staff need training, this is why staff need to think holistically, because it's the same person that's having the journey through manual handling and weight management, and that should be part of their treatment, because manual handling and equipment is not separate to the weight management. The person at the center of it is the same person, and we could do so much better for people.
Yeah. And so you've mentioned some of those that are involved. So you have the person themselves, you have the families as well, which is obviously really key, as well as the healthcare professionals. Are there key themes emerging so far in your research, do you think?
Yeah, so one of the things I think that I often think as a district nurse, and I can be guilty of, is thinking that it's mobility and it's about that functional ability to be able to get out the house and go to clinics or appointments. And actually what I'm hearing from people with lived experience is that actually it's about the mental health, a lot of it, especially since COVID. So the agoraphobia that's stopping them from going, or the microaggressions that they feel they're going to get when they step outside the door, of people looking, maybe not saying anything, but the looks that they get, is there going to be kind of furniture for me to be able to sit on? It's the fear of falling and what would happen if I fell. There are now digital apps and things that people can use, but that doesn't mean that they're suitable for everybody. And so I guess it's thinking about, okay, so what could be a suite of options that we could offer people? But yeah, I think the mental health one is one that really comes through to me, and the internal stigma that people feel of, I should be able to do this by myself. No one really wants to treat me, it's not for me, and they almost discount themselves from treatment. So I think we have got a role there as healthcare professionals to be supporting people and saying, actually, do you know, these are for you, and we want you to kind of have access.
Mm-hmm. And what might that look like for open up to? What do you have in your, I guess I don't know that this would have happened before you started the research, but now do you have any ideas of what that might look like in future, or is it too early to say?
I guess that's where we'll get to, but so we often now have a lot of digital kind of apps for people, and they are often, people will say, well, that's great for people who are housebound or have restricted access, and it can be, but we don't know how well they work for people. They can have real positives in that they're available 24 hours a day, but they can have real negatives if you're digitally excluded. And we know that the kind of socioeconomic patterning of obesity means we've got more people who are living in deprived areas. So we can't assume those are going to work. I suspect I'd be interested in hybrid. So do you see someone for an assessment appointment and then you do things by telephone and online and then you see them again? I think, yeah, there's great potential there to look at different things.
Okay, but I guess we have to wait until you have everyone's perspective to see what the recommendations might be. Very helpful research, so Kath, very helpful.
Thank you.
And I know that we probably have some questions that we need to pick up on, so I'll ask Adele if that's okay, if there's any questions in the box.
So there's a couple of questions that have come through in the chat. So we have one, is the HOPE study UK-wide?
Yes, it is UK-wide, and I particularly, so we've got some good representation from Scotland so far for the wider healthcare professionals, but actually England, Northern Ireland and Wales, we could really do with people like having their say from those areas, so that would be fantastic. Yep, so definitely UK-wide.
Yeah, we've got another one, which is actually what it stands for. Could you remind me what the HOPE stands for?
It stands for Housebound, Obesity, Pathways and Engagement. So it's about these pathways for housebound people and how we can best engage them. That's what we're thinking about with it as the kind of top headline.
Another one from Danielle was, can we be sent any studies or links for the resources?
So I think that the team, we're either going to put the link in the chat, or we could send it round to people afterwards by email so that people can contribute to the HOPE study and look at that. And I do have a kind of publications on my University of Glasgow or my Google Scholar. Although, to be honest, people are probably not going to want to read those academic publications. You're just going to want to read the kind of abstract and the bit at the end. But I think that what we see in this area is a lack of training and a lack of resources for healthcare staff. And I think that one of the things that I see when I talk to people around the country is there's pockets of innovation going on, people writing their own guidance. And it would be fantastic if we could draw that together into kind of national bariatric care guidance. That's a real gap that I see. I think that needs to be seen by the powers that be, the policymakers, to actually employ someone or ask someone to do that kind of guidance. Yeah, I think that's a real need in the area.
Another one then is, so it's from Sally. She said, this is so interesting. Can you let us know how we get any evidence to you?
Yeah, so my email for my Glasgow account is kath.williamson@glasgow.ac.uk. I'm on LinkedIn, so you can always contact me that way. If you Google Kath Williamson, it's a K, and you put University of Glasgow, you'll get my University of Glasgow email. So very happy to be contacted. I do have a kind of wider care needs of obesity network that just send resources out to, or things of interest. So if people want to register for that, if they email me, I could send you the link to the form that you could fill in. I need your permission for GDPR to process your contact details, but very happy to add people to that. I would say I don't have all the answers, but I'm interested in being part of the way that we get the answers. So if people want to link up, I think that really helps.
No problem. And what weight is considered as bariatric?
Yeah, that's a really good question. And so you'll find different policies name different things. Sometimes it's 25 stone, sometimes it's like 30 stone. I take a pretty broad view in that if you limit it to a weight or a BMI, then you're usually going to miss some people out. Because if you say it's 25 stone and you've got someone who's actually quite small and quite short and they're 18, but actually they have their weight around their middle, they're going to have functional limitations, particularly with getting shoes on, bending, care of their lower legs, which I would say are due to their size. So I just tend to take a very functional perspective of it's any kind of limitations in function that people have due to living in a larger body.
Great.
I'm just going to put my email in the chat because I think people are asking for that, because I was very quick with
no
it.
problem. It is being recorded as well, so if you do miss something, you obviously can look back on it as well. So another one then is, hi Kath, you'd mentioned toilet type is a consideration for people of higher weight. We have been struggling to find out weight limits for toilets. How do you find this out?
So I would just look on manufacturers' websites, and what I would say about toilets is it's really important that they are floor mounted and not wall mounted, because if you have someone with a larger body using a floor mounted one, probably the balance of that toilet and the safe working load is going to be lower. So there is some guidance around kind of environmental considerations in so if people wanted to email me, I could probably forward you on a document about that. That doesn't answer your specific question about finding out about specific toilets. That would be kind of manufacturers' websites. But if people do want advice around guidance for environmental considerations for clinics and things, there are some Irish guidance around obesity and weight management.
No problem. Sorry, I'm just reading through this one to make sure I've got it right. So there was, do you have any tips of how to advocate for clients being referred to and or discharged from community inpatient rehab services to need further time resources from the service? So I'm assuming, yeah.
That is a really good question. No is the short answer. I think that sometimes I feel that our organisations don't take into account the needs of people living in larger bodies, and there's almost like an organisational structural stigma in there. And I think that, we just advocate the best that we can. And I think making the case for people being given more time, perhaps because they're living in a larger body and it's harder for them. I think that's the kind of thing that I would love to see evidence on around rehabilitation in the future. So there's lots of work to do in this area. We have definitely not got it all nailed.
Let me just what was the name of the app that you mentioned?
So there are a number of digital weight management providers. I can't recommend one specifically. If you look on the NICE guidance for obesity and weight management, then and kind of filter on digital providers. So there is Second Nature, there's Juniper. Just if you do a Google search, you will find lots of digital providers out there. It doesn't always mean that they're all the same. You would want to look at what evidence base they have behind them, because basically anyone could set themselves up. So I would be looking at whether they've published research, at what their outcomes are. And it's the kind of thing that it's quite easy for people to say, oh, this number of people lost weight using our app. What you want to be looking at is the number of people that started and the number of people that finish, because it's very easy just to analyze finishes, and that doesn't tell you about the overall effectiveness of it. That's a whole other area, really.
No problem. And you mentioned about the push for rehabilitation in the community. Are you aware of any person of size inpatient centres for individuals to be referred to? Many local rehab facilities decline patients secondary to lack of staff, equipment, etc.
I'm not aware of any inpatient. I have heard on the grapevine of maybe a private one, but this is the kind of thing that we need to be pushing into. This is my dream for the future, of having rehabilitation facilities that are set up for people of size, where we have got tracking hoists, we've got kind of walking pants that we can get people rehabilitated with, and I think the bit of my research would hopefully look at is the bit of where is that window to be able to do that for people. So it's a long-term plan that we're thinking here, like 15-20 years of looking forward to the future, but I think there's real hope there. So the answer, I'm sorry that's not a great answer, but it does tell us where we're pushing into and what we need. So if anyone does know of an inpatient facility, please let me know so that I can kind of hand that on. That would be really good information to know.
Is there a way people can get weighed if they're housebound? We need to consider weight limits and equipment.
Yes, fantastic question. And one of the reasons we don't have a lot of evidence about this population group is because we don't have the scales in community. So we don't have the scales, so we don't weigh people, so we don't have the data, so it looks like they don't exist. So therefore we don't have services for them. It's literally a loop. And I kind of wrote this up as the second chapter of my PhD. And so you're looking for bariatric scales that are wider and low profile and go up to like 300 kilograms or maybe 500 kilograms. And for people to be able to take those out and use them in people's homes. If you have a look on my Google Scholar, there's an article which talks about anthropometric measures in the community, and that is all about scales. It's written in an academic way, but it does have an algorithm which will help you decide which scales you need. I think it's the kind of thing we need to be advocating for from managers, by saying that we need these scales to weigh people. Quite often, if you ring around in your ICB or in your health and social care partnership, or try the weight management team, they may have the scales already, and you could maybe borrow them if you ask nicely. But you need to make a risk assessment just about the person's mobility. I would say the person doesn't need to be able to stand for very long. They need to be stand for like 5 seconds to get a reading on the scales. You also get bed weighing scales and you get wheelchair weighing scales as well. So have a look at that article if you want to find out a bit more about that. But that is one of the basic things that we need in place.
I think this may be more of a statement, but it can be so difficult to get special orders approved for funding through our equipment streams for larger service users, and it's frustrating that the solution is often to make equipment wider without increasing seat depth. So standard bariatric equipment remains unsuitable. Don't know if you have any comments on that.
Yeah, I guess this is one of the ways that I think our organisations are structurally exhibiting kind of weight stigma in some ways and structurally disadvantaging this population, because bariatric equipment costs more, and now we've got such budgetary constraints, which I understand that means that more of the bariatric equipment has to go through the special orders, go through the panels, and I get that. I get why that is, but it's actually disproportionately affecting this community, I would argue. There's very little evidence base around cost of equipment, so I think that's something that we need to work on. I would advocate all you can around that. I don't have any major solutions, but it is something that I'm trying to write about.
And finding functional issues with toileting, RE, aperture sizes, and bariatric individuals stating their bottoms being too large and are soiling over the back of toilets, commodes, finding this difficult to address and find solutions for, if you have any ideas.
Yeah, this is a challenging area in this population, and I would say practically you can order essentially kind of bottom wipers, which I think OTs may be aware of, and they may be helpful for people to extend their reach. And you can get those on Amazon. I've got people to buy them off Amazon and things. But I think that one of the things that I uncovered in my qualitative research with people was that often people are struggling and they're so ashamed that they don't want to say. And so I think as professionals, one of the things we can do is help people have that conversation by saying things like, we sometimes find that people similar to yourself or in your situation can have problems with personal care, and that will allow the person to open up about it. Whereas if we don't give them the opportunity, quite often people are living with that and not able to verbalise that that is an issue for them. So I wrote a qualitative paper which has quotes about from people being prescribed pessaries by GPs and they couldn't administer them themselves, but didn't want to tell the GP. That kind of thing. We need to get better as professionals as helping people ask for the help and access the help that they need.
As a company who creates specialized bariatric equipment, how do you recommend we help our current and potential clients?
Fantastic question. I think a couple of the things, there's one of the things we can think about how we name things. So naming things, if we use names that are associated with things that are very large, that can be stigmatizing. So calling it giant something, or we just need to be careful what messages that gives. The other thing I think is thinking in the future, if more people are using the obesity medications, is that equipment going to be able to cope with the adjustments in someone's weight journey? So I think that if we're buying a £12,000 chair for somebody and it is supportive of them, that's great. But if they lose 4 stone, are we then going to have to swap that chair, or is it adaptable to that? So I think that we'll see more variation in people's body size going forward, and for manufacturers it's thinking about how we are going to manage that in your equipment. I can see in the chat that people are really supporting each other with just the difference, giving different solutions. And
Yeah.
I think it's okay to mention this, that A1 Risk Solutions have they have a WhatsApp chat actually for plus size, and that can be quite a useful source of information. So if A1 are able to give the link to that for people getting in touch with them can be helpful, because the kind of things that are being discussed about specific equipment are the things that come up on that chat. Obviously, you need to think about your organizational policies in terms of being on a WhatsApp chat, and you shouldn't be putting any patient details on there. But if it's just about what's available, that can be helpful.
Sorry, I'm just going to quickly run through this to make sure I'm not missed anything.
Thank you for your time, everybody who's had to go. I hope that's been helpful to some degree, even as just helping you talk about these things with people better.
Yeah, I think I've covered everything. If not, if I've maybe missed something, please don't hesitate. Obviously, Kath has given out her email address, but also if there's anything else that we could follow up on as well, if you just make sure to email admin@a1risksolutions.co.uk, we can either forward it on to Kath, or if there's something we can give you information about, we will do that as well. I think if that.
Yeah, I think that's a great suggestion there on the WhatsApp group, but also we will be sharing the link. Adele will kindly do that for participation in the HOPE study. And we are so grateful to you, Kath, for preparing the research. It's exactly what we need in order to develop, whether it be equipment, services, or any aspect of patient-centred care. So thank you from all of us for taking the time to do that. I know how much effort that you're putting into it, and if we can help in any way, then we'd be delighted to do so. So thank you again.
Thank you, Norma. And have your say in the research. That would be the best way to help, is just put your views. It's not a test. It's not a professional test. It's really just picking up on where professionals are. Particularly around the weight management. So it'd be great if you could do that. But thank you very much, everyone, for giving me the opportunity and listening. I really appreciate that.
And yeah, I want to say thank you again to obviously Norma and Kath for joining us in the webinar today. And just a quick, just a reminder that if you haven't been able to attend, you've had to pop out, that it will be sent via email in the post-webinar email, so you can come back and watch the full recording again. So look out for your email as well, because it'll have information on the next webinar. So thank you everyone for attending.
Wonderful. Thank you so much.
Bye-bye.
Thank you. Bye-bye.